finally. It was not me. It was Alondra who helped me out. I had no idea how to do this. Okay, so good afternoon, everybody. So what I wanted to talk about is people living with HIV and, COVID-19. Right now, we went through a lot since March and a lot of changes and, staff stressed out, patients stressed out, and changes in the way we practice basically medicine since this started. So let's talk a little bit about epidemiology. So worldwide, we at the US continue to see a lot of the cases, most of the cases that are diagnosed, around 6 million people we have diagnosed with COVID in the US. I think the last time I checked, it was 6,700,000. And I think that the reason is because we do have the ability to test more than other countries. Other countries who are highly populated also have a high number of patients, but likely don't have the same capacity of testing that we have, even though we think that we probably didn't do a great job. We actually have the best capacity of testing, I think, in the world. And we're followed by India, Brazil, Russia, and Peru. In the US, we've had around 200,000 people die from the disease. In other countries, it has been less. Reporting in the US is probably better than in other countries, such as Brazil, India. And there are other countries where they're also reporting the recovered patients. And if you can see, for example, Colombia is a very small country compared to the US. There has been also a lot of people affected, and there has been a lot of restrictions. And since I'm from there, I'm aware that it's very difficult to actually get tested by the public system. And most of the time you have to get tested and pay for the test. If you can see on this slide, basically what I wanted to show you is that the areas that are mostly affected in the US are, as we know, Florida, California, Texas, and it's in the areas where we see also the higher number of deaths, specifically in the areas that were initially affected, like New York, Florida also. And you can see where more patients are, likely more deaths are followed after, because of the type of disease that COVID-19 is and the difficulty of treating the patients with this disease. Just in the last 7 days, the last time I checked, before when I did my slides, September 19, the number of cases reported in the past 7 days from that day were almost 300,000 cases. So we continue to see cases, even though in Florida, we have seen a decrease in the number of new infections. And right now, the percentage around the state is, I think it's less than 5%, but we continue to see new patients coming to the emergency room. And we are also still taking care of the patients that we diagnosed back in June, August. Some of those patients end up in the ICU for over 60 days with a lot of complications and inability of coming out of the ICU alive, unfortunately. So I want to talk a little bit about things that probably a lot of people that are working in the hospital don't think about, and we do think about, and specifically when we are taking care of vulnerable populations, like people with HIV, living with HIV. The World Health Organization, for example, reported that 36 countries have had disruptions in provisions of ARV services, and that around 73 countries have experienced a risk of actually not giving patients antiretrovirals. From those, 24 countries actually went into having very low stocks of ARVs. And you can think about the reasons this could happen, and it's when a lot of the countries end up in lockdowns, there's difficulty transporting medications from one place to another. We're fortunate, for example, in the US, that we have like a very robust Y&Y program, and we have access to medications via mailing services and things like that. But in countries where it's difficulty even transporting the medications via vehicles or buses, it's even rough to just think about how difficult it must and it continues to be for people that live in countries like that. There has been many disruptions of multiple services around the world, including HIV testing, HIV viral load monitoring. Like a lot of the countries are reporting things like this because of closures of clinics, decreasing the amount of time or hours that they are taking care of the patients, inability to continue to do voluntary services such as circumcisions that we know, for example, are help prevent HIV transmission and acquisition. So, I don't think we've seen right now what could happen to newly infected HIV patients that were not recognized or were going to be delayed in diagnosed or that never received medications because of all the conflicts associated with the COVID-19 at this time. And I think we're going to be probably following up later in the year or next year. We're going to be seeing all the things that this pandemic brought to people that live with HIV. For example, here in our background, there was actually an interruption and disruption in care for our own MHS routinized out of opt-out screening in the ER. We have one of the largest ERs in the South Florida area at Memorial Regional. We had instituted a program there to do opt-out testing for people that just come into the ER for admission or not. And we started that program around June 2018. And up to April of this year, we had conducted 36,000 tests roughly. And we had diagnosed around 192, or we have identified 192 patients being positive. From those, 53 were newly diagnosed. And the Memorial Focus staff was successfully able to link 43 of 50 patients that were eligible for care. There are 3 patients that were not linked to care, and when I discussed they were not eligible to be linked to care when I discussed with the staff is mainly because they were not residents of this country. They were on vacation, and so all the patients that passed away. Furthermore, we were able to re-engage 87% of people that had fallen out of care that were tested in the ER. So we were very, very proud about this program. But since the pandemic hit, there was changes in the way we conduct ourselves in the hospital. Basically, people that were not seen as necessary to be crowding the ER were basically taken out of the ER. So we saw a reduction in the number of testing. Plus, we also saw a drop in the number of patients that actually showed up to the emergency room for care because people were afraid of getting COVID showing into the hospital. And I know that you guys probably have heard that a lot of people just waited in their homes and never showed up. And the incidence of strokes and heart attacks during the most highest surge time increased because of this. And so, and as a result of this, we did see a drop in the number of patients that were tested during that period. And we're yet to analyze what else happened after in our second surge, because up until March, it was between March and April was the first surge that we saw at Memorial Regional Hospital. And we started seeing our second surge around, I think it was at the end of June, all the way to almost 2 weeks ago. There was also a report that came out from the CDC that noted that 28% of STDs and HIV testing sites, for example, in a region such as St. Louis, were closed, and 63% operated with modified services. during the height of COVID-19 restrictions. And I can see that happening around this area too. So as a result, testing for chlamydia and gonorrhea fell 45% overall. And so there was a decline in the number of new infections with chlamydia, gonorrhea, and syphilis during that time for that area. And I would like to at some point see our data from South Florida to probably reiterate that that was also one of the things that we're going to see. One, because people were quarantining at home, and two, because people are just not coming to get care. Also, what I think that is important to analyze is that racial and social demographics also have disparities, as well as we have disparities with HIV with COVID-19. We can see that the most affected ethnic groups by ethnicity or race, with the available data from the CDC, is that COVID-19 has affected a lot of the vulnerable populations that we already know affect HIV too, such as Hispanics and Blacks, not Hispanics, as well as the number of deaths has been also high in the Hispanic and the Black non-Hispanic groups. And you can see also in the white non-Hispanic, but I think that it's important to, in our heads, to analyze that it's kind of the same population that usually gets mostly affected with HIV. The CDC, the New York Department of Health also had some data published after their surge over there. And it was just last updated July 29. So this is what I have, is that the number of cases are mainly related to patients of a Black ethnicity or a race, and Latino Hispanics, less likely whites. And the same for hospitalizations, and the same for the number of deaths. So what are the factors influencing racial and ethnic minority group health? I think that one of the things that's important to recognize that a lot of the patients will work in essential industries with increased exposure to COVID-19, lacking PPE, lacking paid leave, and some of the patients, some of the people that end up sick with COVID could potentially also have HIV, and have difficulty calling in sick into their jobs, and end up probably working sick without telling anybody. There's a lot of residential segregation by race linked to many adverse health outcomes, as we know. People of Black race are more likely to reside in poor areas with high housing density and poor access to health foods. And multi-generational households and limited space may make it more difficult to protect older family members or isolate the sick. Also, access to care. We do know minority groups are more likely to be uninsured, have lack of health insurance. That will restrict the access to health care. Language barriers, financial implications of missing work, and decide to just go get care. And multiple comorbid conditions will increase the likelihood and the severity of COVID-19, also linked to residential segregation, and also increase stress levels due to multiple social conditions and medical issues. So I think that it's kind of like it brings back like the same problems we see around HIV, and I think that adding that, the COVID-19, to the whole thing is like a higher stressor for our patients. I think that the best way to describe it is like a syndemic is defined as two or more epidemics interacting synergistically to produce an increased burden of disease in a particular population. And I think that's what we're seeing with our people that live with HIV. Such synergies are even greater in older people living with HIV who are actually at higher risk for COVID-19 related mortality. So for us to protect people living with HIV from COVID-19 and future pandemics, we must address multiple factors and organize ourselves, who are the people that are helping them, to be able to provide them with direction on how to get care, how to continue following their actual disease they actually do have, and continue to be in care for that particular disease and not be afraid to come out, for example, of their houses or seeking the help to get care, for example, for if they end up getting COVID-19. So having said that, I just wanted to just remind everybody, because of what I said, that a lot of people live in multi-generational households with very little space to isolate. Like, if, per the health department, if you want to isolate someone that has COVID-19, they have to have their own bathroom and they have to have their own bedroom. And it's probably very difficult to do in a lot of the houses where our patients live. So as we know, COVID-19 is transmitted by person to person, specifically by respiratory droplets from coughing, sneezing, or talking. So high level of shedding is usually very evident in the upper respiratory tract at the beginning of the infection. So the first few days are the critical ones. Airborne transmission, there's a lot of debate about that. I personally think that there could be airborne transmission via aerosol generating procedures, or if a patient is in high flow nasal cannula, something like that. But in the hospital, we haven't seen any real airborne transmission with all the protections we have instituted. The other thing that is important to understand is that we have data that is very hard to culture the virus after day 9. But in patients with HIV that are not well controlled and considered immunocompromised, there's some data supporting that we are probably going to see the virus being cultured up until day 20. And I think this is important when we're giving recommendations to patients for discontinuation of isolation, that we probably should recommend for our patients 20 days after their first symptom instead of 9. Okay, so let's talk a little bit about immune-related risk factors for susceptibility to severe COVID-19. So older persons have impaired B cell and T cell immune responses versus younger people. That's why we see that right now the kids at college, they continue to have their parties and they get sick, but there are very few that really get really sick. It's more the older people that have impaired immune systems. And we think that reduced ability to mount neutralizing antibodies could be one of the reasons that people get very sick. We're not sure what is the role of the T cells in the ongoing SARS-CoV-2. It's very uncertain. And then the younger people that we do see that get very sick is likely because they have some type of impaired, dysregulated B or T cell immune response in their bodies. Many conditions can cause a person to be immunocompromised, to have a weak immune system, like solid organ transplant, bone transplants, HIV with a low CD4 count, or not on treatment, prolonged corticosteroid use, or some people that are in immunomodulators medicines. Having an weakened immune system may increase the risk for severe COVID-19, and excess risk of severe COVID-19 in persons with well-treated HIV, I think, is minimal. I think we have all seen it. Like, if you guys have seen your patients in the office, they do get sick, but very, very few of the ones that are very controlled, that don't have any other risk factors, end up in the hospital. So as we know, effective antiretroviral therapy has prolonged our patients' lifespan. And we also know that 1.2 million people are living with HIV in the US around, at this time. Of these, more than 50% are 50 plus years and do have multiple physical complications from long-term antiretroviral use. Older people living with HIV in particular have higher risk of any type of diseases, including diabetes, hypertension, cardiovascular disease, chronic lung disease. And probably those are the patients that are probably going to be at higher risk of getting severe COVID. The incidence of COVID-19 and people living with HIV is unknown. And during the last epidemic with the SARS-CoV-1 in 2002, 2003, there were few case reports in the literature about this disease and people living with HIV. So are people with HIV at higher risk of COVID-19? I think I've talked a little bit about this, but we're still learning about COVID-19 and how it affects people with HIV. Based on the limited data that we have, we believe that people with HIV who are on effective HIV treatment or antiretrovirals have the same risk of COVID-19 as people that do not have HIV. Older adults or people of any age who have serious underlying conditions might be at risk of severe illness. This include, people that have other diseases besides HIV that could weaken their immune system, such as cancer, diabetes, and things like that. People with low CD4 count and people that have HIV and are not taking their medication. That's why it's so important to keep them engaged, specifically during this pandemic. We are seeing now some data coming out from different hospitals. Massachusetts General Hospital reported a series of 36 patients with HIV that, it was a series of 47 patients with HIV, 36 had confirmed COVID, 11 had probable COVID. What they had is that at 77% were non-Hispanic Blacks and Hispanic or Latinos. And in that particular clinic, only 40% of their patients were actually Black and Hispanic Latinos. So this means that this ethnicities were mainly affected, like we were talking before, because of multiple issues. 85% of them wound up having severe disease, had obesity, hypertension, diabetes, hyperlipidemia, chronic kidney disease, like we have seen in the literature for patients that don't have HIV. And there was another publication, a case control study from Mount Sinai, that actually matched 88 patients, matched patients with COVID-19 with ones that have HIV to ones that don't have HIV. And basically there was no difference in the disease severity or adverse outcomes, even if they, depending if they had or not HIV, like there was no difference between the two groups. So I think that, like I say, if it's an HIV that's well controlled and depending on the extra comorbidities that they have, then I think that's when we're going to see the highest risk. Like if they have HIV that's well controlled, but they're also obese, diabetic, they have COPD, hypertension, then that patient is probably a higher risk than a patient with HIV that don't have anything besides that. And what I think that we will also see is that if the HIV is well controlled, then they will be likely at the same risk factor of somebody that doesn't have HIV but has all of the other comorbidities as the patient with HIV. There was another study published in the Journal of Infectious Disease. There were 93 patients that were evaluated. 23 were hospitalized, 19 died, and 53 recovered. The patients who died had a lower nadir absolute lymphocyte count, and and versus the patients that recovered. And they also, if you're familiar with the way we treat the patients in the hospital, they had higher CRPs, higher interleukin-6, compared to the patients that didn't, that didn't do as bad. So basically, no difference in age, sex, BMI, HIV duration, native persisting, presenting CD4 count, or viral suppressor before or during the COVID-19. So what can we do to protect our patients with HIV? Make sure that your patient has at least, I would say 90-day supply, not 30, of HIV medication and any other medication that is important to maintain your patient under control. If possible, like the health department has been doing, send the medication via mail, or other pharmacies that do that, maintain their vaccinations up to date. Establish and maintain a plan to communicate with them with remote clinical care and telephonic encounters, as a lot of us are doing, trying to do telemedicine to communicate with the patients. And if your patient is really, really undetectable and stable, and you might want to consider delaying their medical appointment and lab appointments, just especially in the surge times, so they are not, going into public transportation to get to your office to try to get, the lab done. What can people with HIV do to protect themselves? I will say, no changes at this time unless absolutely necessary. If they have persistent HIV that you diagnosed during this timing. But otherwise, I wouldn't put them under stress of getting new side effects or anything like that. Encourage your patient to maintain social network remotely, such as online, by phone, or by video chat. And people with HIV can sometimes be more likely than others to need extra help from friends, family, neighbors, community health workers, and others. Encourage your patient to stay in touch by phone or email with people who can help them. So it's important to have people around them. It's a scary time. Some of the patients just disappear and don't want to talk to anybody, but it's not good for their health. So on the first part here, if I can show you, this is actually what happened at Memorial. Our first patient that we diagnosed was March 7. I actually was the person that saw that patient. At that time, we were not doing the test at the hospital. We were sending it to the health department. So we started collecting the data. In the red is the number of patients we started seeing after March 15. This right here is our first surge, which we thought was the worst surge in the world. And actually, the peak for that surge had 160 patients. So if you can look at the other side of the screen, what we end up doing was we end up closing the office on March 23 and then transition everybody to 100% telemedicine. One of the reasons the offices were closed was because most of the staff was deployed to help with COVID related things at the hospital, including some of our doctors were deployed to take care of patients with COVID in the hospital, including myself. And so we had to limit the visits for our patients to 100% telemedicine. I couldn't put another slide here, but at that time, our no-show rate was almost 35%. And I think that, there was a lot of reasons. There's a lot of unknowns. We were creating all the clinic recommendations on how to handle the patients and what to do to screen them. And, everybody was scared of getting COVID. So, multiple things happened at that time. Then when it is eased up, we said, okay, let's just go ahead and start reopening. And we started seeing patients at 35% capacity in the office. But what started happening was we started seeing in other offices at Memorial pockets of COVID-19 transmission from patients to employees, and then from employees to employees. And so we slowly went back to, again, 100% telemedicine appointments, and that coincide with our next surge, if you can see on the first picture. At that time, we had a maximum number of patients in the hospital that was around 670, and our Memorial infectious disease practice was taking care of a lot of those patients. Most of them did not have HIV. And so right now, where we are is we're going down and we're plateauing, and we are seeing new patients in the hospital, but it's not as many. So we are able to redeploy a lot of the staff back to their normal practices. But we have always been open with telemedicine appointments. We've always been here for our patients. One thing that happened that was great is that patients right here were not engaging too much into the telemedicine situation. Right here, they're engaging more. And here, I almost have no-shows every day. I think our no-show rate is less than 10%. And we are all already starting to open to seeing patients in the office too. But a lot of the patients right now are preferring just to talk to us via telemedicine, and we're able to take care of them like that. So we will continue to do so until we feel we can transition back, but we will keep telemedicine open because I think it's a very important tool. And I've thought about this for a long time. It was just hard to implement, and the buy-in from the patient was difficult. But I think that now they understand that they can use it and it's important. So one of the things that we implemented was a drive-through testing in the back of our clinic. We have a clinic that I think it was a McDonald's before, I can swear, because it has like a drive-through thing. So we were able to have one our nurses get dressed up and go outside and get test our patients for COVID, which we implemented because it was very hard to get them into the public sites at the time of the biggest peaks. And patients were getting very stressed out on not knowing where to get tested. And also a lot of the commercial labs were taking a long time to report their testing. And so we decided to do it in the back of our clinic. So this is Angela. I'm sorry. This is Angela, one of our nurses. And she continues to do it to this day. She was collecting today. So far we have tested 86 of our patients, symptomatic or that were exposed. We're not testing anybody that just wants to get tested because that will be too many patients and a lot of disruption to our office. So we're just testing people that are symptomatic or were exposed. Most of the patients that are positive are basically symptomatic, and most of them are males. But I think it correlates along with the number of males that we do have at our office too. And their ages range from, around 20 to 70 years old. And you can see that the most affected age is between the ages of 15 and 59. This is a quick case of one of my patients that did end up in the hospital. I just wanted to bring it up because I want you to remember that we give patients medications that have a lot of drug interactions and could potentially harm the patient if they do something with any of our patients in the hospital and they don't know that there is a drug interaction. So my patient is a 39-year-old female that was diagnosed with HIV in 2006 with a CD4 count that was less than 200. She developed multiple resistance through the years due to non-adherence, and those are the mutations, for people that knows about this stuff. Right now, she is on darunavir, ritonavir, and combivir. One of the reasons we still have her on combivir is because she doesn't want to switch to anything else, and she's been doing good with this regimen, and she has a K65R, so cytobudine is what we're trying to use here. So she ended up in the emergency room with cough, myalgias, fevers, chest pain for 5 days. She had a fever when she came in. Her ferritin was high, her C-reactive protein was high, LDH was high, and then she was positive for COVID-19. The husband was also in the hospital. She was also just hospitalized for a few days. She was discharged. And then 7 days after she was discharged, she calls our office and tells the nurse that she's seen something strange in her hands and that she doesn't know what to do. So she sent us a picture via my chart, and we were able to see what was going on. So I was familiar with this presentation, and that's probably associated to COVID. A lot of people after getting infected with COVID end up with some type of embolisms of clots that are very minuscule, and they can cause something like this. So I sent her back to the hospital, and she was started on anticoagulation. So the whole story is to tell you guys that when they started her on anticoagulation, they didn't realize that there was a drug interaction with the darunavir that could potentially cause bleeding. So because we follow our patients very closely, we were able to catch that there was a drug interaction, and we were able to switch her to the appropriate regimen. And she is now doing very well. So for our drug interactions with potential COVID-19 treatments, there's not a lot of treatments, but there's a lot of things they're giving them in the hospital, including steroids for a long time. So if you have a patient that is on a PI, you don't want to have them on very high doses of steroids because it can increase the levels even higher. They're giving them zinc, they're giving them like a bunch of vitamins that will, interact with Biktarvy, dolutegravir, things like that. Some people are also taking over-the-counter stuff, and they're not telling you. I've had patients actually that were not undetectable on the last test because they were taking this zincs and things like that to prevent from getting COVID that they heard from the friend that could potentially help. And as of today, none of those vitamins are actually proven to do any benefit. People give them, and some people give it in the hospital, but there's no proof that it helps. Hospitalized patients with HIV basically just continue the ART, try not to change anything that the patient has not taken in the past. If there is any off-label drug that they're going to use, I recommend that they do consult somebody that knows about HIV in the hospital, because there could be potentially some drug interactions with any of the newer things that they are promoting for treatment of COVID. And I wanted to remind you guys that our patients, I will say that they should be under the 20-day. If they, it is a little bit controversial, but I would just say 20 days to be safe, to make sure that you can discontinue transmission-based precautions. Don't use testing strategies, no longer recommended. We initially started doing this, and patients test positive for 120 days. I recently had one that 5 months after is still testing positive. That doesn't mean they have COVID still. It means they have particles of COVID in their body, and they're just like trying to get rid of it. So I will never think that they have chronic COVID. It's probably just the old infection and the shedding from the old infection. What can we expect? So after the pandemic, what can we expect? I think that we can expect that we're going to have recurrent outbreaks after our initial, and I think that we've seen that. We saw a little peak, and then we saw a big peak, but there are several models that this pandemic could follow. This will be the best, a slow burn. We had a big peak. We had a little peak, a big peak, and then just slowly burn it out until either we get a vaccine that is effective or everybody gets infected. And then we have enough antibodies in the community that people don't get sick. or something that a lot of people are waiting for, and it's a high fall peak, maybe with the flu, hopefully not. That's why it's important to everybody promote your flu vaccinations. And we're going to probably do the same thing that we did with the testing. We're going to do a drive-through flu vaccination in our office in the back. And then the other possibility is just have peaks and valleys. And I think right now we are probably here, or maybe here. We'll see what happens. But this is going to be something that we have to be prepared for the next 18 to 24 months on significant COVID-19 activity with periodic hot spots across diverse geographies. And then lastly, we could not do it without teamwork. And this is my team. There are some people that have moved on, a couple of people in that picture, but mainly this is our team here. And this is a pre-COVID-19 picture. Thank you.
Dr. Eckardt, there was a question in the chat.
Okay, let me see if I see it. What's the question?
It said, you mentioned staying up to date on vaccine. Is a pneumonia vaccine recommended, and at what age for our HIV patients annually?
Oh, okay. So, yeah, everybody should be, any of the vaccines recommended for patients with HIV. We know that Prevnar 13 should be given to the patient when they never received it in the past. When they come to see you for the first time, you should give it, followed by the Pneumovax 23. So I think that you shouldn't change your HIV practice because of COVID. And it should be, the Prevnar 13 is just once in a lifetime, and then the pneumonia 23 should be given every 5 years for 2 times for age 65, and then after age 65, 1 time. I think that's it.
All right. Thank you, Dr. Eckardt. We really appreciate your presentation. Once again, thank you everyone for attending this session. We have another session tomorrow on trauma-informed care. So if you would please join us if you have an RSVP on our website, and we implore you to sign up for any sessions that you're interested in for the rest of the week. Once again, we really appreciate you and your services and everything that you do for our patients. So just have a pleasant afternoon, and we hope to see you again this week. Thank you.